Imagine applying medicine to an active burn, only to realize you've been putting the ointment like 3 inches away from the actual fire.
Oh, yeah. It sounds completely absurd.
Right. But for decades, this has basically been the standard medical reality for millions of women going through menopause. I mean, we usually picture the human body aging in these broad, sweeping strokes.
Like a house settling over time.
Exactly. The foundation shifts, the roof gets a little leaky, and everything just sort of uniformly wears down together. We expect our internal organs to follow a single, predictable timeline.
But they really don't.
No, they don't. And today, we are unpacking a massive biological disconnect for you. We're doing a deep dive into a really fascinating anatomical mystery regarding the human vagina.
Specifically focusing on how the elasticity of the vaginal introitus.
That's the entrance, right? The distal region.
Exactly, the entrance.
Mm.
We're looking at how that specific area changes completely independently of the deeper vaginal canal during aging and menopause.
Which is wild.
Yeah.
Because, it really upends that traditional generalized view of reproductive health.
It does. Historically, medicine has treated this entire anatomical region as one uniform environment.
Yeah.
Just a single tube that ages exactly the same way from front to back.
But our stack of medical research and, biomechanical studies today reveals something entirely different.
Right, because the localized changes in the tissue, which are driven by hormones and biomechanics, they reveal an incredibly complex microenvironment.
And when we talk about this kind of aging, particularly as estrogen drops, we are looking at genitourinary syndrome of menopause, or GSM.
Right.
But GSM isn't just a single symptom, is it?
Not at all. I mean, GSM is the modern encompassing term for a whole constellation of changes. It includes vulvovaginal atrophy, which is the physical thinning and drying of the tissue.
Yeah.
But it also covers the pain, the changes in elasticity, urinary frequency, and even recurrent infections.
Wow, so it's a huge umbrella.
It is. And the crucial thing we're going to explore today is that GSM doesn't hit this entire system equally. The changes are hyperlocalized.
Right. So to understand how this area ages so differently, we first have to understand how it's actually built.
Which is where your house analogy works perfectly.
Yeah, I like to think of the introitus, the entrance, like the specialized, heavily fortified entryway of a house.
With the deadbolts and the weather stripping.
Exactly. It's got a reinforced frame and a security door. Meanwhile, the deeper vaginal canal is like the long, flexible hallway leading into the house.
Right.
They're attached, obviously. They are part of the same building, but they are constructed from entirely different materials for completely different purposes.
That's spot on. Because the deeper vaginal wall's primary evolutionary job is to accommodate massive temporary distension.
Which is vital for childbirth.
Exactly. So to achieve that, the hallway is built out of this rich meshwork of elastic fibers and fibrocollagenous tissue.
Wait, fibrocollagenous tissue, is that essentially like the biological spandex of the body?
Biological spandex. I love that. Yeah, that's a great way to visualize it. It's a matrix of strong collagen fibers intertwined with stretchy elastin.
So it can bounce back.
Right. It's designed to stretch significantly under immense pressure and then recoil back to its original shape.
Makes sense.
That deeper canal also features a vast submucosal plexus, which is a dense network of thin-walled blood vessels.
Okay, what do those do?
Those vessels allow fluid to passively diffuse across the lining to provide lubrication.
Got it. So that's our flexible hallway, spandex and passive fluid.
Right.
But the doorway, the introitus, is built for something else entirely.
Completely different. The lower end, specifically around the hymeneal region, uniquely contains skeletal muscle mixed right into the fibromuscular layer.
Wait, skeletal muscle, like what's in my arm?
Exactly like that. You do not find that skeletal muscle deeper in the canal. It's typically the kind of muscle you have voluntary control over, like in your arms or legs.
Wow, okay.
Its presence right at the entrance provides structural fortification and control.
So it's literally the security door.
Yes. But here's the kicker. During the reproductive years, this entire system, both the doorway and the hallway, is highly dependent on estrogen.
Estrogen is kind of running the whole show, right?
It is the conductor of the orchestra.
Yeah.
It maintains the collagen content, and it promotes the production of acid mucopolysaccharides.
Okay, hold on. Acid mucopolysaccharides. That sounds like a heavy-duty industrial cleaner or something. What is that doing inside human tissue?
I know, it's quite the mouthful, isn't it?
It really is.
Just think of acid mucopolysaccharides, along with hyaluronic acid, as the biological mortar holding the cellular bricks together.
Okay, mortar.
Yeah, these molecules are incredibly good at trapping and holding onto water, so they keep the tissues plump, hydrated, and resilient.
Oh, gotcha.
Estrogen also ensures the cells are well glycogenated. And as those superficial cells naturally shed, healthy bacteria, lactobacilli, they eat that glycogen.
Oh, and they convert it into lactic acid, right?
Exactly.
That.
Which keeps the environment highly acidic and hostile to pathogens.
Okay, so the fortification comes specifically from that skeletal muscle at the entrance, which you don't find deeper in the canal.
Right.
And because the core building materials are fundamentally different, spandex and passive fluid diffusion in the back versus skeletal muscle and active defense in the front.
The way they break down is going to look completely different.
Exactly. When the estrogen disappears, they are going to react in totally different ways.
And that brings us to the trigger. Because whether it's natural menopause, a surgical ovarectomy where the ovaries are removed, or even certain cancer treatments, estrogen levels eventually plummet.
And when that happens, the doorway reacts first.
Yes, the introitus acts as a canary in the coal mine. According to the histology, it is exquisitely sensitive to hormone static.
Exquisitely sensitive.
Yes. The early clinical manifestations of GSM, the intense loss of elasticity, the contraction, the severe thinning,
Yeah.
they are far more pronounced at the introitus than they are in the upper, deeper vagina.
Wait, I'm stuck on something here.
Okay, what is it?
If the ovaries stop producing estrogen, the whole body experiences that drop.
Systemically, yes.
So the blood vessels at the entrance and the blood vessels in the deep canal, they are drinking from the exact same depleted well.
Right.
It's the same circulatory system delivering the same low levels of hormones. So how can the entryway react so much faster and more violently than the hallway?
It's a great question. And it comes down to evolutionary biological imperatives.
Okay, how so?
Well, the primary job of the introitus involves immediate barrier defense. It is the literal boundary line between the internal organs and the outside world.
Right, it's taking the brunt of everything.
Exactly. It experiences significantly higher friction, mechanical stress, and exposure to external microbes than the deeper canal ever will.
So it has to be on high alert.
Always on high alert. Because of these intense, constant demands, its cellular turnover is much faster.
Oh, I see.
Its genetic triggers are wired to respond instantly to hormonal shifts because it simply can't afford to be compromised. It's engineered as this hyper-responsive early warning system.
But this isn't just surface-level wear and tear, is it? I mean, based on the studies, the tissue is literally rewriting its own genetic code in response to this change.
That's right. It goes all the way down to the genes.
Yeah, when we look at the atrophic introitus, the tissue suffering from that estrogen drop, there are massive alterations in specific genes.
Which ones, specifically?
Well, we're talking about the activation of genes associated with wound healing, angiogenesis, and apoptosis.
Right. The tissue at the entrance is actively remodeling itself, and it basically thinks it is in a state of emergency.
A genetic freakout.
Exactly. Angiogenesis is the attempt to form new blood vessels, usually in response to tissue starvation. But the changes in apoptosis are particularly revealing here.
Apoptosis is cell death, right?
Yes, it's programmed cell death. It's a totally normal mechanism where damaged or old cells are cleanly dismantled by the body.
Okay.
But here, at the introitus without estrogen, that genetic signaling goes into absolute overdrive.
So, without the protective moisture and the plumpness provided by estrogen, the everyday mechanical stress and friction are essentially causing constant micro-traumas.
Okay.
And the genetic code just hits the panic button, initiating a chronic wound healing response and accelerating cell death to triage the damage.
And that profound genetic panic is fiercely localized to the introitus.
Just the door.
Just the doorway. The deeper vagina is not aggressively altering its structural matrix in the same way, even though it's experiencing the exact same estrogen drop.
That is wild. You've got to be wondering at this point, if you're listening, how deep does this localization go?
Oh, it gets even deeper.
Right, because we know the blueprints are different and the genetic panic is different. But the most mind-blowing piece of biochemical proof comes down to a molecule called ENO.
Yes, the Enos paradox.
Let's dig into this mechanism, because this is where the whole uniform aging theory completely falls apart. What is ENOS?
So Enos stands for endothelial nitric oxide synthase.
Okay, that's another mouthful.
It is. But basically, nitric oxide is a vital signaling molecule in the cardiovascular system.
What does it do?
Its main job is to tell blood vessels to dilate, to open up, relax, and increase blood flow.
Okay, and blood flow is crucial here.
Absolutely. Healthy tissue elasticity and engorgement rely entirely on robust blood flow delivering oxygen and nutrients.
So if estrogen drops, you would logically expect blood flow to decrease everywhere across the board,
I
right?
agree.
Less hormone, less blood flow,
That's the logical assumption, but that is not what happens.
which is the crazy part.
In the distal vagina, the introitus area, a loss of estrogen does cause a massive decrease in enos activity.
Okay, so the blood vessels lose their signal to dilate, the blood flow chokes off, and the tissue starves.
Right. But in the proximal deep vagina, a loss of estrogen actually increases enos activity.
Wait, it increases it.
It increases. It's a complete paradox. It proves these zones are following diametrically opposite biological instruction manuals.
But how? How does the exact same chemical trigger cause completely opposite reactions in tissues that are literally just inches apart?
To understand the why behind this paradox, we have to look at the different survival strategies of these tissues.
Okay, walk me through it.
The deeper canal is primarily smooth muscle and elastic tissue, right? It's geared for massive distension, relying on that passive diffusion of fluid from the blood vessels.
The hallway.
Right. So when systemic estrogen drops, the deep canal detects the starvation and effectively panics. It upregulates enos in a desperate compensatory attempt to force the blood vessels open.
Oh, wow.
It's trying to maintain whatever passive fluid diffusion it can to save the primary reproductive conduit. It's a localized survival mechanism.
So it's trying to keep the lights on and the hallway open.
Exactly. But the introitus, which is heavily interspersed with skeletal muscle and specialized sensory nerves, is wired for immediate mechanical defense.
Right, the security door.
So when estrogen disappears and the structural integrity of the tissue begins to fail, the introitus takes a completely different evolutionary path.
What does it do?
Instead of trying to stay open, it dials down ENS, deliberately shutting off the blood flow to essentially close up shop.
It just boards up the windows.
It initiates a full lockdown. It thickens and tightens what's left into a rigid barrier to protect the internal organs from the outside world.
That is incredible. One area desperately tries to stay functional and open, while the other goes into complete defensive lockdown.
Exactly.
So when the elasticity actually snaps, we aren't just talking about things feeling a little dry.
Not at all.
When the structural proteins degrade during this lockdown, we see the hyalinization of collagen.
Right. Hyalinization, which means those resilient collagen fibers degenerate and turn into a stiff, glassy substance.
Imagine taking a fresh, bouncy rubber band and leaving it out in the sun for 5 years until it's just, brittle and cracked.
That's a very accurate comparison. And simultaneously, the elastin fibers, the things that actually provide the recoil, they fragment and break.
And this specific degradation hits the introitus exceptionally hard. It results in a condition called introital stenosis, right?
Yes, introital stenosis.
Because when the collagen degrades, it doesn't just get a little tight, the tissue physically narrows.
Yes, sometimes shrinking so much it becomes completely rigid.
And the clinical definition of this stenosis is the entrance literally contracting to a width of less than 2 fingers.
That's correct. It becomes entirely fixed.
Meanwhile, the deeper canal undergoes a completely different physical transformation.
Right, the hallway. It might lose its rugae, those accordion-like folds that allow for stretching.
Okay.
And it might shorten overall, but it doesn't experience that intense, rigid narrowing at all.
Which makes me think it seems impossible for a doctor to diagnose this with just a visual exam or a standard subjective check.
Oh, it is incredibly difficult.
Right. If the doorway is rigidly stenotic, but the hallway behind it is undergoing a different kind of atrophic shortening, a physician would need some sort of localized pressure map to actually understand what they are looking at.
Which is exactly why the introduction of vaginal tactile imaging, or VTI, is such a massive leap forward in this field.
VTI, what is that exactly?
VTI is a sophisticated form of elastography.
Okay.
Think of it as computerized palpation. The VTI probe utilizes a massive array of pressure sensors, up to 96 high-resolution sensors depending on the model.
Wow, 96 sensors.
Yeah, and it acts like highly sensitive, calibrated human fingers. As the probe is inserted and applies slight pressure to the vaginal walls, it measures the exact resistance it encounters.
Oh, so it's actively drawing a 3D topographic map of the elasticity gradient.
Yes, precisely. It definitively maps out the varying elasticity between the anterior and posterior walls, and crucially, between the rigid distal entrance and the proximal deep canal.
That makes total sense. And this objective measurement is absolutely essential, especially given the complexity of a woman's pelvic history.
Oh, definitely, because life happens before menopause.
Right. Many women experience childbirth, which physically stretches the dense connective tissue of the vaginal walls and introitus.
which can cause varying degrees of physical laxity.
Exactly. The tissue is irreversibly stretched out from mechanical trauma. But then, decades later, the hormonal drop of menopause hits.
Setting up a dual reality.
Yes. A woman could be dealing with connective tissue that was physically stretched out and loose from childbirth years ago, while simultaneously dealing with an introitus that is chemically narrowing, thinning, and becoming rigid today.
And that dual reality is exactly why a generic diagnosis of, vaginal laxity or loss of elasticity is completely inadequate.
It doesn't capture the whole picture.
Not even close. You can have a deeply lax, unsupported pelvic floor in the deeper canal, paired with a highly rigid stenotic introitus at the entrance.
So tools like VTI are critical because they force medicine to recognize that the doorway and the hallway have vastly different structural realities.
Exactly.
Which brings us to the most visceral consequence of all this independent aging, and that's the day-to-day reality of the patient.
Because the pain is very real.
Because when a doorway aggressively shrinks and locks down, it doesn't happen quietly. This dictates the patient's actual pain experience.
Yes, it does.
And it reveals a massive, glaring flaw in how we currently treat this condition.
The pain aspect is profoundly linked to this localized tissue lockdown.
How so?
Well, as the introitus thins, loses its protective acid mucopolysaccharide padding, and physically contracts, it becomes incredibly vulnerable.
Right.
But the pain isn't just from a lack of lubrication or padding. The vestibule and introitus area literally begin to grow a higher density of pain nerve endings.
Wait, really? Neuronal hyperplasia, meaning the nerves are physically multiplying.
The nerve fibers proliferate, yes. The current understanding is that this is an acquired condition mediated by healing cells called mast cells.
Mast cells? What are they doing?
Mast cells are basically the body's first responders to injury or irritation.
Okay.
Because the fragile introitus is constantly subjected to microtrauma from basic friction, without its estrogen-supported defenses, these mast cells swarm the area.
Trying to fix it.
Right. But in their overzealous attempt to heal the tissue, they excessively release a protein called nerve growth factor.
Oh, wow. So it's a localized alarm system gone completely haywire.
Exactly.
The body grows new pain receptors specifically to warn you not to touch the damaged area.
And this results in provoked vestibulodynia.
Which sounds painful.
This isn't just mild discomfort. This is severe, searing, or cutting pain from stimuli that shouldn't normally hurt at all.
Like what?
Like the touch of a cotton swab, wearing tight clothing, or the initial attempt at intercourse.
Wow.
The newly grown nerves at the entryway are on hyperalert, firing off intense pain signals at the slightest provocation.
Wait, hold on. I'm having a massive realization here. If the entrance is where the nerves are multiplying and the tissue is physically shrinking into a rigid ring, and all that genetic panic is localized to the doorway.
Yes.
But a standard medical applicator for hormone cream goes all the way deep in, aren't we just completely bypassing the problem?
That is the ultimate paradox of current standard care.
That is insane.
We know the introitus is where the earliest, most severe atrophic changes, gene alterations, and pain receptor proliferation happen.
Right.
Yet the most commonly prescribed treatment for genitourinary syndrome of menopause involves an applicator designed to deposit topical estrogen deep into the proximal upper vagina.
We are literally applying the ointment 3 inches away from the active burn.
Really are.
We're sending the medicine to the hallway, assuming it will just sort of soak through the entire house, when the front doorway is what's actually on fire.
It is a profound disconnect between anatomical science and clinical practice. For decades, the applicator design has bypassed the introitus, operating on the flawed assumption that the entire organ acts as one uniform sponge.
That will just absorb and distribute the hormone therapy equally.
Yeah. But as we've established, the introitus is a distinct, walled-off microenvironment with its own opposite biochemical reactions.
And the really frustrating part is that we know topical estrogen works.
Oh, absolutely it works.
Right. When applied correctly, it lowers the pH, it restores the glycogen and the lactic acid ecosystem, it halts the genetic panic, and it improves blood flow.
It does all of those things.
But if you're dispensing it past the specific area suffering from introital stenosis and neuronal hyperplasia, you are starving the exact tissue that desperately needs the intervention.
Precisely.
It's wild to think that a simple piece of plastic, designed for convenience or just out of a historical misunderstanding of localized anatomy, is actively standing between a patient and actual relief.
Because knowledge is only valuable when it is applied accurately.
Well said.
Understanding that the introitus ages and changes completely independently means our clinical treatments must be targeted directly to that distal tissue to be truly effective. If the medical goal is to reverse the glassy hyalinization of collagen, open up the stenosis, and calm down those hyperactive mast cells, the medication has to be physically applied to the introitus, not just deposited in the deep canal.
It completely reframes the whole conversation.
It really does.
I mean, to summarize this incredible biological journey for you listening, the vaginal introitus and the deeper canal are two completely distinct, fiercely independent environments.
From the very blueprints up.
Right, we started with their different blueprints. The skeletal muscle fortified at the entrance versus the elastic, spandex-like meshwork deeper inside.
And we saw how a systemic drop in estrogen triggers totally different survival strategies.
Exactly. We examined the enos paradox, where blood flow signals literally move in opposite directions. The deep canal desperately trying to open up, while the introitus goes into a defensive, rigid lockdown.
And we talked about mapping that physical lockdown, the severe stenosis, using the computerized palpation of vaginal tactile imaging.
And finally, we uncovered how all of this hyper-localized aging results in mast cells growing extra pain nerves at the entrance.
Leading to that massive treatment paradox.
Right, where standard medical applicators are literally shooting past the root of the problem. The introitus loses its elasticity and ages completely independently of the upper canal. And it's well past time. Our medical treatments actually reflect the complexity of that biomechanical reality.
It really requires a paradigm shift in how we view anatomical systems.
Absolutely.
And, it raises an exciting, really provocative question for the future of medicine.
What's that?
Well, if the entrance to the reproductive tract has its own entirely unique aging clock, its own genetic panic responses, and opposite chemical pathways compared to the tissue just inches away,
Yeah.
what other localized microenvironments in the human body are we currently treating with a broad brush, just waiting for us to look closer?
Oh, wow. That is a phenomenal question.
Right.
If the front door and the hallway operate on completely different biological instruction manuals, what else is going on in the rest of the house?
We might just have to rethink everything.
We just might. Thank you so much for joining us on this deep dive. Keep questioning the world around you, keep demanding to know the why and the how, and we'll catch you on the next one.